to do that as well. So welcome to you all. So Dr. Pirio Richardson is joining us today. She is a movement disorder specialist at New Mexico. She is head of the program at the University of New Mexico, as well as the VA healthcare system. So Dr. Pirio Richardson, I'm going to let you do more of a background on how you got into movement disorders and open up the topic today. But I want to welcome you and thank you for joining us. This is a very important topic because I think that most of us can see how it would be easy to potentially evaluate somebody's movement disorders from a motor symptom perspective virtually. But doing non-motor symptoms, sometimes things you can't even see might be a little more challenging.
Great. Well, thank you very much for the invitation to talk today. I very much appreciate it. So I'm a movement disorder neurologist. I've been in practice for about 12 or 13 years. I did my fellowship training at the National Institute of Health and have been heavily interested in my clinical care, my clinical practice, and taking care of people with Parkinson's and other movement disorders. But I am also a researcher. I do research in dystonia and Parkinson's disease, both NIH and Department of Defense funded, as well as therapeutic trials. So I'm interested in Parkinson's from all of those perspectives. And there are, I would say, not very many silver linings to the COVID crisis, with the exception of the acceleration of our ability to really do telehealth. And it is something, as I'm a VA provider in the Veterans Administration, and we have done telehealth for a very long time because we have a different insurance process in the VA system. So it's been a part of my life for a very long time, and I've found it very, very helpful. But now we're all able to do it much more, and it's much more accessible. So it's a really important tool for us to do, but it can also be a frustrating tool and be a challenging tool. And so I'm hoping to hit on some of those things today in terms of some tips and tricks, but also to talk about the features of non-motor symptoms of Parkinson's that we really need to address in these video calls. So I'm going to go ahead and share my screen. I have a slide presentation. Okay, so I'm going to focus again today on this virtual visit on non-motor symptoms. And so I wanted to first start with what that virtual room is. So when we think about a successful visit in Parkinson's, whether we're dealing with motor or non-motor symptoms, we envision something like this, where the provider is in their office or possibly at home and interacting over televideo with a patient who's in their home, who is either through a smart device, a tablet, a phone, or a laptop or computer. And this is the ideal situation, right? Where you can see each other, hear each other, and the visit's accomplished successfully. And you can see how the cardinal symptoms of Parkinson's would lend itself to a video visit, right? Tremor is something that's an obvious motor sign that we can see and we can evaluate. As long as we point the camera in the right ways, we're able to do that and evaluate tremor quite well. Stiffness, which is another part of Parkinson's, is a little more challenging to evaluate over televideo. And we may spend more time talking about symptoms related to stiffness, including difficulty dressing, getting arms into sleeves, getting wallets out of pockets, getting in and out of chairs. But we can tell to some degree the amount of stiffness someone's experiencing by how they get out of a chair, how easily they move around the room. But that's a little bit challenging. Slowness is something that we quite readily can do over a virtual visit. I'm sure everyone knows the routine and sticking your hands out and tapping fingers, opening and closing hands, screwing in light bulbs, and if we adjust the camera, being able to watch people tap their ankle or their foot. So we're able to readily look at slowness. And finally, we can look at walking problems, right? If the camera's set up and the environment's safe, we can watch someone walk quite easily over a teleneurology or a telemovement disorder clinic. So those are all things that we can see and we can do well over that. But of course, many symptoms of Parkinson's are not seen, they are experienced. And the only way that we can get that information is by communicating and either having it by self-report or by the provider questioning the patient in order to get that information. Although I'd like to have X-ray vision, not something that we have right now. So we really rely on that information transfer in order to get at all of those non-seeing symptoms of Parkinson's that really impact on quality of life. So that's what I'm going to focus on for the most part. I want to go through each of, I picked several non-motor symptoms that I think are particularly important for the number of people who have these symptoms, but also for the impact that they have on people's quality of life and why we really need to focus on them. And then we'll end with some tips and tricks, and then I'm happy to answer some questions. So in terms of the non-motor symptoms that I've picked, and this is really where this talk came from, was my personal experience with a patient in terms of assessing cognitive changes and some other non-motor symptoms, because they're really important that we pay attention to those in these virtual visits. So the first is cognitive changes. We're also going to talk about GI problems, gastrointestinal problems. We're going to focus on blood pressure changes. There's a bunch of changes that happen in Parkinson's, including changes in heart rate and sweating and other parts of our automatic nervous system. But I'm really going to focus on blood pressure changes today. Also want to talk a little bit about mood changes and sleeping changes, which are really important for us to think about as well. And then finally, we'll touch on urinary problems. This, of course, is not an exhaustive list. The organizers did not give me all afternoon to talk, so I did not focus on everything, but I think these are important things for us to talk about. And so the way we'll go through each of these is to focus on symptoms, and then we'll talk about the evaluation. So cognitive changes encompass a wide variety of symptoms. So the first thing is cognition. It's just a general term about mental abilities. So it really covers everything that we want to talk about. One aspect of cognition that changes in Parkinson's is memory. Memory can change. And that can manifest as forgetfulness, right? The going from one room to the other and forgetting what you did in there. I did that several times this morning, but becoming more and more of a challenge in terms of activities that need to be done, financial things that need to occur, events that need to be attended. So more and more forgetfulness. Confusion can occur as part of a memory disorder. And then another part of cognition that can change in Parkinson's is executive function. And this is a big overall term. I mean, we think about executive, it's called executive function, and we have executives in the business place because one of the functions of an executive is planning. So planning for the future, laying out the right steps that need to occur for something to be completed. Organizing and initiating action, we put all under the same umbrella as an executive function. And then language can change. And again, language is part of cognition, and the things that can change, I think very commonly people have difficulty with forgetting names, which is part of a memory problem, but also we can put this under language, so forgetting names. And I think the most commonly expressed language difficulty that people have are difficulty finding the right word at the right time. And often it's coming too late, or the wrong word is coming up, or even just a blank. And then the last part of cognitive function that can change in Parkinson's is visual spatial function. And this is, important in things like estimating distance, being able to give directions to a location. But it can also be things like putting together a puzzle. And although that seems like something that, may not be life-changing, those skills of being able to, for instance, move obstacles out of a way in going across a room is part of our visual spatial functioning. And if that's impaired, those kind of things don't go well. So that's an overview of the cognitive changes that we're talking about in terms of the symptoms that someone might have. Now, the question is, how do we get this out in a virtual visit? And you'll see the same format for each of these non-motor symptoms. And the first is report, right? You have to tell the provider whether any of these things are going on. So bringing that in a list of things that you're concerned about. So the report from the patient is really, really important. That's where we get most of this information. You can also bring witnesses, people who can provide extra information, care partners, spouses, friends, children, who can help add to that report of what those symptoms are and how they're affecting someone. And sometimes people don't report, maybe aren't aware it's an issue or haven't considered it because we focused on things like tremor and stiffness and slowness and walking changes, which are all really important to focus on as well. So I typically would also question someone. I would, as part of a virtual visit, I'd ask, have you had changes in your memory of thinking? Are you having problems remembering things that have happened recently or forgetting to do things? And based on the report from the patient or caregiver and the answers to the questions that I pose, we may do some additional tests. And so we have, of course, our bedside cognitive testing that we can do, but we can also do this on the website as well. So we can administer different kinds of standardized tests to look at how people's attention and memory and planning and language are doing. And it might give us an idea of whether there's something more serious going on that we need to pay attention to. And that might lead to an in-person, more extensive testing, for instance, with a neuropsychologist. And here's just an example of even over the website, if someone can come with a piece of paper and a pencil, we can do something like the clock draw, where we have people draw a clock and set the hands at a particular time to understand some of those issues with visual spatial function, how people are planning. So this is all something that can be accomplished in a virtual room and really give us some good insight and information. All right, so I'm going to turn now to GI problems, gastrointestinal problems. And we'll focus first on symptoms. So the most common GI symptom that we discuss in terms of non-motor symptoms is really constipation. And that's because almost everybody experiences this. They can certainly experience it prior to the development of Parkinson's, and certainly in the throes of Parkinson's, very many people, the vast majority of people experience it. And that's because our gut has its own nervous system. So just like the effects Parkinson's has in the brain and in our central nervous system, it has those same effects on our gut nervous system. There's additional things that can happen. There's slow emptying of the stomach. And so that medications and food and all of those things aren't getting to the right place at the right time. Drooling, the sort of going from the whole GI tract, I would put drooling in here because this is certainly something that can come up. And this is generally not because you're producing more saliva, it's because those automatic reflexes to cause swallowing aren't happening as often. And so people can have drooling, sometimes just at nighttime, but can occur during the day as well. And then difficulty swallowing. This certainly moves over into sort of a motor symptom as well. But I put it here because, again, it's something that I put in my list of things to ask people about. Most common symptoms are coughing or choking. And of course, the reason we care about this is it can lead to infections in the lungs. So the way we evaluate this is not going to come as any surprise, it's the same way, is report. A patient reports this as a symptom when they come in, we need to deal with it and talk about it. More information from family members or care partners is the other way we get information about these symptoms. And then I often ask questions, and these are the kinds of questions I ask. Are you having difficulty with constipation? What are you doing for it? What kind of symptoms are you having? Are you having drooling? Is it happening just at night, or is it happening during the day as well? How bothersome is it to you? What have you tried? And then, of course, are you having any choking or coughing when eating? We might get a little more detailed there and ask questions about, does that just happen with liquids? Does it happen with solids? Is it because of dryness? Certainly some of our medications cause those kind of things. And we might get more specific on that. And then what are the tests that we do for this? Well, that is a challenge over the website, that we can certainly elicit whether there's a problem or a symptom going on in the GI tract. Especially if we're dealing with choking or coughing, we probably refer someone off to a speech therapist for a more intensive evaluation, some of which can happen over a virtual visit as well. They might get some more detailed information so that the in-person visit's shortened and very discreet in terms of what they need to do while you're there, but they can get some of that additional information over a virtual visit as well. All right. And as part of that speech therapy, one of the tests that they might do is something called a barium swallow in order to assess the swallowing apparatus. So I'm going to move into another non-motor symptom that I think it really can impair people's quality of life, and those are blood pressure changes. Again, we don't think about the heart and the blood vessels and as part of the Parkinson's system, or the part of the parts of the body affected by Parkinson's, but it certainly is, and is certainly affected by our medication treatment. So symptoms like lightheadedness, especially when going from sitting to standing, are important symptoms that are non-motor symptoms of Parkinson's or related to our medication side effects. And again, this is on changing positions. It certainly can happen moving from laying to sitting, but most frequently it's from sitting to standing when people experience that. It can get more extreme, right? Feeling like you're nearly going to faint, not just lightheaded, but you might faint or black out. And if you don't sit back down, that's gonna occur. And then it can progress to actual fainting. It is not uncommon and affects about 1 in 5 people with Parkinson's. And I'll give you an example. So if you're in a seated position and let's say you have a blood pressure of 120 over 80, let's all hope that's what the blood pressure is, it's a good one. And then if you go from, and you're feeling fine, not lightheaded, no symptoms, you go to stand and that blood pressure drops to 90 over 50. So this meets our criteria for what we call neurogenic orthostatic hypotension, or NOH, where the blood pressure, those numbers on the top and the bottom drop too much. And what that can lead to is exactly the symptoms that are listed above. It can make you feel lightheaded, make you feel like you might faint, or actually faint because you don't have enough blood flow to the brain to sustain you being standing, which is why the fainting happens, to get you down on the ground and restore blood flow to the brain. So the way we evaluate this is the same way. I rely on report from my patients, from care partners, on whether these kind of symptoms are happening. And sometimes the report comes from a care partner noticing that every time someone stands up, there's a minute where they steady themselves, maybe hold on to something nearby, and then go ahead and keep walking. And that might be our first clue that someone's having that experience. So I ask people very directly, do you feel lightheaded on standing? There's a bunch of other symptoms, a big list here that may be associated with these blood pressure changes. Headache, difficulty concentrating, impaired vision, neck and shoulder pain, shortness of breath, chest pain, weakness, fatigue, and nausea. Many other causes for all of those symptoms aside from blood pressure changes. But if people start reporting some of these symptoms or more than one of these symptoms, it might make me want to get their blood pressure checked, sitting and standing, to make sure that that's not something we should be doing something about. And then finally, in terms of tests, the way we do this, and I know many people have blood pressure monitors at home, we take readings. So you can take a blood pressure reading lying down. You should also get the heart rate at the same time. That adds additional information for us. We then check the blood pressure sitting up, and then we check the blood pressure immediately on standing and about 3 minutes later to see how the nervous system is responding to that change of going from lying to sitting to standing. So that is something that I do have. It's not infrequent that people have a blood pressure cuff at home, and we actually do those readings and can get that additional information. Of course, if we can't, and I'm concerned, we'll bring people into the clinic for a nurse visit to get those readings done, but it is something that we can do over a virtual visit and treat and discuss right there. All right, I'm going to move on to our next non-motor symptom, which is incredibly important and really can impair people's quality of life, and that is mood changes. And this is challenging for a variety of reasons. And again, is something that is not necessarily outwardly seen. We know that the facial expression and some of the changes due to Parkinson's may make it even more difficult to see these changes. And so in this case, we are really going to rely on people's report and response to questioning. So the mood changes that can happen in Parkinson's vary widely. They can, I just listed a few of them here, but certainly not all of the ones that can exist. But the main ones that we screen for and pay attention to are depression. It affects up to 40% of people with Parkinson's. And I think what we mean there, I think depression and fleeting feelings of sadness and periodic times of adjustment to disease, to diagnosis, all affect everyone at some point. But when we say affects up to 40%, we mean is really an encompassing difficult symptom that's really affecting people's lives that we need to treat. It's this feeling of persistent sadness. And again, as I said, sometimes challenging to diagnose because of the features of Parkinson's. So things that make it challenging. In someone without Parkinson's, new insomnia might be a sign of depression. In Parkinson's, we know sleep disorders, and we'll talk about this more, can occur just because of Parkinson's and the changes happening in the brain. So sometimes that's hard to know whether to lump or split these symptoms. Apathy, or this loss of get up and go, is often a symptom in people who don't have Parkinson's that we think is a sign of depression. But just that loss of dopamine neurons in Parkinson's can cause people to have apathy, or that loss of that get up and go, so may not be appropriately attributed to depression. Change in appetite is also often something that we ask people, but we know people with Parkinson's have changes in appetite because of a loss of sense of smell and may not have the same appetite. And so that can make it tricky to know whether that's something that's attributable to depression or is attributable to Parkinson's. And then, as I said, that loss of facial expression is something that we use in folks who don't have Parkinson's to diagnose depression. And we use that as sort of a marker of how people are responding to treatment. But in Parkinson's, we know that's one of the primary motor symptoms, and that's not going to change even with appropriate treatment for depression. Another mood change that can happen related to Parkinson's is anxiety. That's excessive worry, sometimes manifests as some irritability. And then another mood change that can happen either as a part of Parkinson's or more commonly as a result of our medications that are trying to increase dopamine levels in the brain. We can have hallucinations. These are when people are seeing or hearing things that are not there, and they're not uncommon at all. I'd say probably with the right with increasing doses of medication, that number probably goes up, but many of those mild hallucinations are non-intrusive, and so not something that we need to deal with. But I like this disparity where there's many people who experience it, but very few who discuss it with their providers. And so if we're not asking about it or reporting it, we may not be able to help with it. So hallucinations come in a variety of forms. I gave you 3 forms here in terms of bugs and animals, and those are not uncommon for people to experience. Even more common are, we call them passage hallucinations, or just a brief shadow in the periphery of the vision, making you take a second look to see if there's something there. There are, people can have auditory hallucination, hear something that's not there. It's most commonly things like radio sounds, music, phones, doorbells. And sometimes it's hard to know whether or not it's a hallucination or not, because they're all really common sounds. Again, in the vast majority of people who have hallucinations, they are not worrisome, bothersome, or cause suffering. But for some people with Parkinson's who have hallucinations, it really could be causing suffering and worry and pain because of the experience. So it is something that we need to monitor and pay attention to, because changes in our medications can help. So as I said, the report is the most important thing. If the patient reports it, or from family members or other people who are attending the virtual visit, that's where we get most of our information. And then I directly question people. Do you see or hear things that you know are not there, or are told are not there? Because again, you've trusted your brain for a very long time. So these experiences feel real. But if you're repeatedly told that there is nothing there, then maybe we need to talk about this discrepancy of why there's something different going on. I also ask people if they're feeling sad, low, or blue, which again, all of us experience those feelings, sometimes intermittently during the day, and especially now in this pretty challenging time. But we want to make sure that we're screening to make sure this isn't persistent or happening most of the time. And then I ask people, are you feeling anxious, frightened, or panicky? And what do we do for tests? Well, there's some rating scales, there's some forms people can fill out to give us some idea of the extent or depth of the symptoms. But usually just a questioning and a discussion is sufficient for us getting to whether or not this is meeting criteria for being a mood change related to Parkinson's, like depression, that we may need to think about treating. And in some cases, I might suggest an evaluation with a psychiatrist or a neuropsychiatrist or geriatric psychiatrist, who, especially given the complexity of medications and the side effects that people with Parkinson's might experience, we might bring in a psychiatrist as part of the team. All right, so then I'm going to move over to sleeping changes. And again, we're going to go through the symptoms first. There is a wide range of symptoms that occur with sleeping changes from Parkinson's. Sleep apnea can occur whether or not you have Parkinson's. Sleep apnea, which is where you stop breathing temporarily during sleep, can occur, and that causes all kinds of problems with daytime sleepiness and other things. Really commonly, people can have difficulty falling asleep, which is insomnia. They can also have frequent awakenings during the night. So able to fall asleep okay, but then up pretty quickly multiple times during the night and have to be able to have difficulty going back to sleep. Another thing that we ask about, and certainly is something that occurs very frequently, is nighttime urinary frequency. So not uncommonly, people get up at night to urinate, and when that's occurring maybe one time a night and you're able to go back to sleep, that's not really intrusive. But when that happens 3 or 4 or 7 or 10 times per night, that really can be intrusive. The other thing we ask a lot about are vivid dreams or nightmares accompanied by movement, which is something that often can be known as REM behavior disorder. So REM sleep is when we dream, and normally during when you're dreaming, our bottom part of the brain stem, paralyzes the body, except of course your diaphragm, so you keep breathing. And we are not able to act out our dreams, Because Parkinson's affects that same part of the brain, patients can have the ability to act out their dreams and really have some big and violent movements. And one of my favorite, one of the challenges though, of course, is the person who's having this occur, unless they strike someone else, strike a wall, or fall out of bed, may not know it's happening. And I remember giving a talk at a support group quite a while ago. And I finished my talk and I went to sit down at the back of the room, and the next speaker was a sleep specialist. And the first question he asked was, who out there has REM behavior disorder? And there was one gentleman who raised his hand. The rest were spouses pointing at the patients because they were the ones who had known or experienced that symptom. And I thought it was such a good visual for why people patients don't report the symptoms. And it's clear because they're going through their normal sleep cycles, they're going through normal sleep. And so unless it affects someone else or they have some notification that they've fallen out of bed or moved too much, they may not know that it's occurring. And then nighttime confusion can happen, and maybe part of the sleeping changes that happen in Parkinson's. And then of course, as part of that, the confusion can actually move into some hallucinations or delusions that happen at nighttime during sleep. So as I said, the most important thing is report. And again, some of these things patients may not recognize that it's occurring. And so we do need information from other folks who might be affected by it. And I ask people about insomnia. Do you have difficulty getting to sleep, or do you have trouble with frequent awakenings, staying asleep? Do you have intense, vivid, or frightening dreams? And do you ever talk or move about in your sleep as if you're acting out a dream? In terms of tests, again, we're really just going to ask questions about this and talk about it. There are situations, for instance, I take care of a veteran population in my job at the VA, and many of our veterans have been affected by post-traumatic stress disorder or PTSD. Sometimes I really can't tell whether it's REM behavior disorder related to Parkinson's or PTSD, and so I would then recommend a sleep study so we really know what we're dealing with and we use the right treatment for folks. And then I'm going to focus on my sort of last non-motor symptom that I wanted to bring up today. And then we'll talk a little bit about some hints and tips in terms of the virtual visit. So in terms of urinary problems, again, urinary frequency, which is this need to urinate often, certainly occurs in Parkinson's. You can have urinary urgency, which is the feeling that one must urinate right away, and that often can be worse at night than laying flat. And then you can have urinary hesitancy, which is when you have difficulty initiating a urine stream. So again, no surprise here. We have to talk about it. If patients don't bring it up as an issue, or care partners, spouses don't bring it up as an issue, then I will ask people if there are any issues going on there. Do you have a sense of urgency, a past urine that makes you rush to the toilet? Try to get some ideas of things that are troublesome, and especially this nighttime urination, because of its effect on sleep, is something that we'll ask about to get that information. So in terms of tests, again, we will ask questions, and we may start on some preliminary treatment, but sometimes this would result in having an evaluation with a specialist who might have some ideas to help these symptoms. So I know a little bit of a whirlwind tour, but wanted to focus on, I think, some of the main non-motor symptoms that really can impair people's quality of life, so that we can focus on them. And as you saw, that's what I do every time, is I try to leave things open at the beginning in order to get that things that are bothersome from people, from their report. And then I sort of have a task list. I call it my Parkinson's disease review of systems, and I'll go down that sort of checklist of questions to make sure we've covered it and given people an opportunity to discuss those issues if they're bothersome. And sometimes people don't know that they might be related to Parkinson's, so didn't bring them up. So I think it's really important to go through that questioning process. So in terms of some tips and tricks of going through a virtual visit, especially on non-motor issues, again, we have our ideal scenario, right? Everything's working, everyone's smiling, everyone's happy, no one's frustrated with the technology or the system. They haven't had to mute themselves because they're frustrated. um, uh, so here you are, right? You're in your individual space and you've got your laptop up, you've got a smartphone up, you've got a desktop computer with a camera attached to it. And you've got your Wi-Fi working, you're connected to the internet, everything looks good, right? And then you get in the room and you can't see me, or I can't see you, or you can't hear me, or I can't hear you, right? This happens, right? On occasion, this is a challenge. So what do you do? So I know you guys have, there has been some presentations on virtual visits, and there's many different resources in order to get help on how to use the different platforms that people are using. But one of the first things that I would just, as a general rule, talk to people about is your browser, so your software that you use to search the internet, right, to get into a Google search engine matters in terms of this technology. So that's one of the first things that I talk to people about if I have to call them, because we can't see or talk to each other, is I say, make sure that you're using something aside from Internet Explorer. Chrome, Google Chrome is very compatible with many of these programs. There's Safari on there, there's Firefox. There's a bunch of different options if you're not comfortable with Google and Google Chrome. But that would be one of the first places that I would start is check what your browser is, and Internet Explorer has some limitations when it comes to some of these televideo platforms. So that would be the first place I go. The second thing is I'd ask you to take advantage of the trial run. So our institution has a trial run where when they're making the appointment and get your email address, they'll ask, do you want to do a trial run to make sure everything's working and we can go through the video hookup, the sound, to make sure that things are working. And I found that really helpful, so that when we get into the visit, we don't have to spend a lot of time troubleshooting. We're actually able to do what we want to do. And so if there is an opportunity with your provider to be able to do a trial run with their office staff or with someone else, I would take advantage of it. Even if you're experienced sometimes with a new platform, depending on what your provider uses, it's worth doing that. So if there's an opportunity for a trial run, I would take advantage of it. And then one of the challenges, right, when you're just ahead on the computer is you can only see where the camera is pointing, right? And so as part of web etiquette, right, this new etiquette we have on the web, is it's really important to introduce who else is in the room, who's providing information. So everyone who's in the room needs to be introduced so we all know who the players are. I think that's really important to do. I don't know how the cats got into this one, but they're there. My cat would never stand for that. In any case, because what we don't want is this effect, right, of the peanut gallery, which happens to me sometimes, and I'll hear someone yelling from a hallway, giving information. I don't know who it is. It could be a caregiver. And I'm really disoriented because I can't see. I can't look around the room and figure out what's going on and what kind of information is there. And so as much as possible, making sure that everyone knows who's participating in the call so that we know what we're talking about. It's especially important if we're going to start asking some of these really sensitive questions about non-motor symptoms, that I know who's in the room too, so that I can ask the question in an appropriate way. So, but I'm going to end with two quick stories. The first one is on a success of televideo and how it was helpful for me. And then the second on maybe what not to do. So this is a typical exam room, right? And you can see that this is normally how I'd have my patient come in. And if I'm questioning them about symptoms they're having, they may bring up that they're having difficulty with falls. Great. What am I going to do? I'm going to ask them to stand up and go ahead and walk and look to see what's going on. And of course, when they do that, they're successful. We've got an exam chair that actually has arms. It's rigid, so it's easy to get out of the chair. There's no obstacles in front and no visual challenges to overcome. And people walk fine back and forth, sit down in the chair, right? Whereas at home, so I had an appointment set up with a patient who was having some falls, and we wanted to talk about them because they weren't happening outside the house, they were only happening inside the house. And so I said, let's have a video call. So here they are on their couch. This is obviously not their couch, but my Googled image of a couch. So the patient, sitting on the couch, we're talking. And shortly after we started talking and I went through the exam, I asked them to tilt their camera down so that I could have them tap their feet and see what was going on. And as soon as they do that, the first thing I see there is a lovely dog right under their feet, right? Beautiful, beautiful dog. I can't believe this dog's eating a carrot, but in any case, that's my image. And then jumping into the scene is another dog, right? And then as I look around, there are throw rugs everywhere, covering the carpet. And so right there, right, we had some interventions and things we could do that helped that, I was distinctly at a disadvantage in our clinic room at knowing what the scenario was and what was going on. And so, we're not getting rid of the dogs, nobody worrying, no dogs were harmed. We're just moving them right out of the situation, making people aware of the challenge here, right? That reflexes are not happening as quickly. So any of these obstacles need to be removed in order to give you the best chance of success and not falling. So that was a win for a video visit. And then here's my not a win, what not to do. So one of the challenges is, right, technical stuff is going to come up. Another patient who has deep brain stimulation, electrodes in, and was having some trouble walking. So I wanted to see what the gait change was in order to decide if they needed to come in for some programming changes. And so as we got set up, the gentleman was actually in his car, pulled over to the side of the road and called in onto his phone. And what you're looking at is what I looked at for the entire visit, which was his ear, because he couldn't hear I don't know if the volume wasn't turned up, something was not working for him. And so, of course, we didn't accomplish what we needed to accomplish in that visit because I couldn't watch walking, I couldn't do anything except look at his ear. And understandably, he was frustrated, I was frustrated because we had a goal and we couldn't get to it. We brought him in and were able to handle the situation in person, but it may have been something that we could have done over a video visit, but technology sometimes gets in the way, and so we move on. It's not going to fit every particular situation, but in this case it unfortunately was a miss, even though many times these virtual visits work very well. But if they don't, then people come in and we take care of them. So anyway, I guess I'll say I'm all ears for any questions that you might have. And I appreciate your attention and time today. So I'll go ahead and stop sharing.
Okay, that was fantastic. And so really having the virtual visits can be a real benefit, it sounds like, if you have everything working, because it's a window into someone's environment that you don't get when they come into your office. So if someone's saying, I'm falling, and you ruled out things like, neurogenic orthostatic hypotension, and other things that can contribute, you could see maybe it's because of the positioning of the throw rugs, the way the furniture is, or maybe there's just a lot of clutter about that, might be an obstacle. So I think that there may be, it sounds like, some real benefits to see into their world, what they're actually living in every single day that might impact or contribute to any concerns.
Yeah, absolutely. I mean, I think that, that was a perfect example of where that was helpful and we could really talk about some practical things. Because as everyone on this call, I'm sure knows, there's no magic pill to stop people from falling. I'm sure wish there was. I mean, I'd be writing that 12 times a day if I had that available. So we've got to think out of the box, figure out ways to keep people safe in their home environment. It's also kind of an intimate thing to welcome your doctor into your home. And I try to be respectful of that as well, because it's, I'm in my office here, which again is my sort of personal space, but in someone's home, it's even more personal. And I really appreciate the opportunity to be able to be welcomed in and be able to see people in their home environment.
Absolutely. All right, we've had quite a few questions
Okay,
related to the symptoms. So I actually tried to categorize them. So I'll go through the different questions based on the different topics that you reviewed.
sure.
So I'm going to go back to just the way I have them. I don't know if they're in exact order. Cognition. So one person said they have difficulty multitasking. So I don't know if you want to address that. Um, and, I guess
Sure.
that's just a general and multitasking problem.
Yeah, I would say, that's definitely a misnomer. None of us can multitask. It means our brain is shifting tasks very quickly. So we feel like we're doing multiple things at once, but we're not. And one of the big challenges that happens in Parkinson's is that to do every either motor or cognitive task, you're using so much more of your brain than someone who doesn't have Parkinson's. Those motor commands, some of the cognitive commands are very efficient when you don't have Parkinson's. And in order to accomplish them, in Parkinson's, you have to use the entire brain apparatus in order to accomplish what you need to. So that symptom of not being able to multitask is very real and is a very big part of Parkinson's, because you are using the whole brain at once and you really can't shift from task to task in that same quick way. I would say that it's something really important to notice, and we definitely question, and certainly falls in that cognitive domain. There are some medications that are called cognitive enhancers. We don't really have memory pills, because if we did, I'd take them, probably 4 or 5 times a day. If we did, right, we'd all be on them. But we do have some things that sometimes can help with some of those symptoms. So it's important to bring it up and talk about it, but very, very common experience.
All right. The other question in regards to cognition was, when do you feel the person with Parkinson's might first start suffering with cognitive decline? And what percentage do you feel of patients suffer with it?
That's a great question, and an area of some controversy right now. I would say, and I uniformly tell my patients, it is not inevitable that because you have a diagnosis of Parkinson's, that you will have intrusive cognitive problems as time goes on. I would say because of that shift in how the brain works and how the resources are being used by the brain, it is common that everyone experiences some change. And for many people, that will remain the same over time or very slowly change. But for a subset of people, they will have a more aggressive or more a quicker progression of that of cognitive changes. And I think we don't know enough about why that is or what that is. We actually just put a big grant in because of this question that we really don't understand, and we can't predict from the outset who might be affected and who isn't, because clearly as we get to
Oh boy. Oh, we froze a second. Dr. Pirio Richardson, can you still hear us? Okay, she's back on.
Yeah, I apologize. That was our VA network just went out for a moment. I'm not sure why. I should have put it on the Wi-Fi. But yeah, now I'm back on. I apologize. Maybe it's telling me I've talked too long. We don't know who to predict, but as we get into these therapeutics that might actually change or transform the course of the disease, we'd sure like to know that. Some of the changes in that cognition are probably because of the different areas where the Parkinson's disease is actually affecting, and that's why you see that difference.
Okay. I thought this was an interesting question related to blood pressure. So this person says my blood pressure is normally low. It drops when I stand up. It doesn't drop enough to be considered NOH. Nevertheless, I've passed out a few times. Why would that happen if my pressure doesn't drop that significantly?
Good question. So there's 2 parts to that, and I'd say those numbers are numbers. Your experience is more important, right? The fainting is an incredibly serious sign, right? You can't protect yourself when you're falling. No matter what the blood pressure changes are, it's something that we have to think about and address. But it might, if it's not cannot be attributed to the blood pressure change. There's other things that happen. So the first big change that happens in Parkinson's is going from sitting to standing. Everyone's blood pressure drops a little bit, but our heart rate goes up. We call it reflex tachycardia on standing. Normally our heart rate goes up, and that allows enough blood flow to still get to the brain, because the output of the heart is related to blood pressure and heart rate. So there's two factors there. As time goes on, that effect of the heart rate not responding to even a small change in blood pressure could result in not getting enough of that blood flow to the brain. So there's other things that can be going on. So that's why I always check blood pressure and heart rate. It's possible you need to see a cardiologist. There may be something else going on there. But those numbers they're the place we start, but clearly fainting's a big deal and we really need to pay attention to them.
And one person just asked, with an OH, do you recommend compression socks, abdominal binders, and drinking more water?
Yeah, I think all of those things make sense in terms of, blood pressure is a pipe problem, right? So you need fluid in the pipes, you need volume in the pipes. So you need water, but the only thing that keeps water in the pipes is salt. So you need salt and water to keep the water staying in the pipes where the salt is, which is normally not and that's why you take out salt if you have high blood pressure, right? It's to get rid of that fluid. So you need volume, and then you need pressure. Abdominal binders sort of make sense to me. Above the waist compression hose, and I never say that lightly to someone who has Parkinson's. I can't imagine how long that would take to get on and to get off, but those are probably the most effective. The compression hose that goes up to the knees really just help with swelling for the most part. I would say they're not as effective at that pipe problem of keeping pressure. So if you can use an abdominal binder or pressure, you can raise the head of the bed at night, because that changes how much of a hormone you release and how much water goes out with the kidneys. There's a bunch of, I think, non-pharmacologic tricks that you can use in order to try to get that blood pressure up.
All right, so I'm going to move on to the category of mood, and we had several comments and questions. So one person asked, would you consider addictions a non-motor symptom, such as gambling and addiction to sugar? And is that the same as obsessions?
Yeah, great question. And I clearly wasn't comprehensive in all the things that can happen. I tried to focus more on symptoms that are more related to Parkinson's itself rather than perhaps medication side effects. And although that's not entirely clear in Parkinson's, many times the impulsive or compulsive disorder, so I would put those together. And so the compulsions can be eating, sugar, gambling, hypersexuality, shopping, would go in that category. And oftentimes those seem to be related to dopaminergic stimulation or our medications that we're using to replace that dopamine loss. So to me, that they are absolutely, you can absolutely qualify them as non-motor symptoms, but may be related to our therapy or therapy-related effects. Although I know there's a wide range, and I've even had patients with deep brain stimulation develop some of these things. So we're in the anatomy where this can happen, whether or not we're stimulating electrically or with medication. So it's a very important thing, can really impact on people's quality of life as well as their financial health. There's no question that we have to pay attention to those. And my review is not meant to be exhaustive, so thanks for bringing that up.
Fantastic. So I think this is a really relevant question too, especially when you're talking about your assessment and including the family members, because often they see and recognize things that maybe the person with Parkinson's does not. But this person's asking, what if I live alone? What if I don't know if I'm hearing things that aren't there?
Yeah, so this is a tree falls in the forest kind of question, right? I think it's a hard one to answer. I would say, and because we know, again, this is all about anatomy. Our limbic system, our emotional system uses dopamine. When you give extra dopamine, you're going to affect that system. So it's not an unexpected side effect to have some kinds of hallucinations. I'd say if medications are working well, your motor system's working well, and you're not bothered by something that, whether it's real or not, then it's okay. Then it doesn't need to be brought up. It's not something you have to report, or be concerned about. It's not something that needs to be screened. Now, somebody who's experiencing, and I've had folks who've lived alone and felt like there was a presence or something in a closet, right? And this was starting to make them worry about living at home, being on their own. That's something I care a lot about, right? Because that's going to change their trajectory and whether they can stay alone. And that I'm going to pay attention to. But if you heard a door, whether or not you know it's real, if it's not really impacting you or bothering you, I'm not sure we have to assess it in that way.
One person's comment was, how come all obsessions are tied to bad stuff and no one gets addicted to kale or smiling? True.
Very nice. Yeah, boy, that does say something, doesn't it, about how our brain's wired and how we're all developed. Yeah, I love it.
Well, we only have a couple more minutes, and I wanted to ask quickly about sleep. And you mentioned sleep studies. So I've heard, is it possible to do virtual sleep studies? Can they do them from the home?
That's a good question. I know I think we may get to a point. I don't think that's able to be done right now. There are companies that can come in and put equipment like something called an EEG or electroencephalogram on at home, and then we get that data remotely and are able to make assessments about potentials for seizure, people having seizures. In the sleep study, there's a few other pieces of that need to happen in terms of being able to monitor your oxygenation. Because people move, you often have to put this equipment back on, which is why they're done in a monitored setting. But I suspect that's not too far away. And I would say with this big push to be able to keep people safe in their home, but still get the care that they need, this has driven a lot of technological change that I'm hopeful we'll be able to allow people not to have to come in and stay in a hospital to get some of these things done, but it could be done in their own home.
Fantastic. Well, Dr. Pirio Richardson, I have to say you did a fantastic job doing a great overview of non-motor symptoms and how you assess those virtually. And I think that we're hoping that this stays, because I think there's definitely a place for telemedicine. I think it is very beneficial, gives you a different viewpoint. So thank you for sharing your insights today with us.
Thanks for the opportunity. Very, very happy to talk today. Thanks very much.
Okay, well, everyone, I want to thank you so much for joining us today. We hope to see you again this week in our other presentations. Again, Dr. Pirio Richardson, thank you so much for joining us. If you don't have your windows open so we can see your faces, your video on, we love to say goodbye by giving everybody that wave. So enjoy the rest of your Tuesday. It's great seeing you. Thank you so much. Bye-bye.